recorded on Yugambeh land. We acknowledge their traditional custodians, elders past and present, and all Aboriginal and Torres Strait Islander peoples. Please note that MP in Progress is an independent project and is not affiliated with any health service organisation. To ensure confidentiality, all identifying features have been removed from the case studies to protect patient privacy. The content shared here is for teaching and learning only and should not be used as a substitute for professional medical advice or evidence-based clinical decision-making. Always refer to current guidelines and collaborate with your healthcare team in practice. You ready to go?
If this is shit, you can just delete it.
Oh, mate, I edit, don't worry.
You could.
Everyone has their thing that they say. I say, I know or like, and
Yeah, I say yeah a lot. I'm like, yeah.
So it's fine. I've got editing software.
Okay, cool.
Welcome to NP in Progress. We have another awesome guest, Ben Leamont. Ben and I are colleagues from way back now. We're both emergency nurses, and Ben's tapped into a special niche, toxicology, and I love it. When I worked at the PA, I loved every second working there. There were so many amazing people, and Colin Page is a true foundation to this toxicology unit and everything that you are essentially. He's taught your mentors. He's created so many amazing things, and he did that by himself. He was on call for maybe 365 days.
Oh yeah, he did something silly, and then when Kath started, I think they were on call just doing week blocks at a time. It was something, I don't know how they sustained that, but I think like any of those services, to try and get something new off the ground, trying to provide something that's going to be useful for people, they had to sacrifice a lot, and it's all paying off for them now.
The first question I ask every guest is, tell me about your journey from being a registered nurse to NP.
Yes, well, it's probably not that exciting, but I started nursing back in 2009, and that was back in Rockhampton in the emergency department, and did my graduate year there, another year. And I think that's probably where my little flame for being a nurse practitioner was ignited. There were two amazing MPs in ED, and they took me under their wing, and they were definitely my mentors. And I was just in awe of what they could do, I guess, coming out as a grad nurse and being brand new, deer in the headlights, and seeing how two high-functioning MPs can work and what they can achieve and with their scope. I think that was probably when my flame was ignited. And then I did what most people do in smaller towns, and you've got to go to the big smoke to see what it's like. And I was lucky enough to get a job in ED with you, Yaz, at the PA, and I've been there ever since. So that was back in 2011. And it's an amazing department, and I've had lots of great opportunities there and worked my way up and doing CNC things. And then we have something that's a bit unique to the PA, where we have a Rove service. So we have a dedicated clinician that goes and sees potentially aggressive patients. So I think that's where I got some of my autonomy, and that sort of rolled into toxicology. I always had a pretty keen interest in tox. I think it's probably one of those things you like to have someone who's unwell and instigate some treatment and then improve quickly, and then they move on and through to discharge. I think tox was always one of those ones that you come in, someone's GCS3 not breathing, and you give them an antidote, and now they're awake breathing again, and you fix them within minutes. I think that was one of the things that drew me to tox, and it was just, we were lucky enough to have like you said, a clinical tox unit at the PA created by Colin Page back in 2014. And he went off and did some additional training down in Newcastle and brought back his skills and started the unit, which has then grown to what it is now. Kath Izawadi is the director, and she's going from leaps to bounds. She's an amazing woman. She doesn't waste 1 minute of the day. She just gets things done, and so she's growing. And she saw the utility of nurses and how they can improve patient care for our poison patients. She developed a nursing subspecialisation course, which was started a few years ago, that I was lucky enough to be one of the two people to do that for the inaugural one. And then that sort of just flowed through. I completed that, and then that flowed into, I was approached by my ADON at the time, and then by Kath to suggest that I should do my nurse practitioners. And I'm really glad that I did. I guess going back to that point as well, it was quite easy for me to say no, only because I had a lot of family things going on at the time. My second child was actually born on the first day of uni, so I was going through my head that I should just do this in a few years, and when the kids are a little bit older and things might be a bit easier. But as a nurse practitioner, practitioner in mental health at the PA, and I was speaking to him about it, and he said, no, definitely get it done now, get it done while the kids are young, where they're not going to realise that you're not there and you're off doing some study and things. I'm really glad that I followed his advice and did this early because, well, Noah's turning 3 soon, and I remember it to this day that he was born on the first day of orientation week. So I didn't actually get to attend the first week of uni, but that was okay. The course coordinator, Aaron at the UQ, he's a great guy, and he was more than happy to oblige and me having that week off. And then here we are now. So yeah, I've been working as a nurse practitioner in the tox unit at the PA nearly a year. So I started in February last year. So I'm still all new to this, still learning things every single day, but it's a great job. I'm enjoying the Monday to Friday, and I'm enjoying going to work and learning something new.
I guess we should really define what toxicology is first before we get into the day of the life of Ben. Yep. So what is toxicology? Because it's not just overdoses, is it?
No, so we're a unit within the emergency department, but separate. So we look after anyone who presents poison, whether that be deliberate self-poisoning or accidental ingestions or occupational ingestions or recreational overdoses. So a lot of methamphetamines, all your party drugs, uppers and downers, and then envenomations as well. So it's definitely snake season at the moment. We get all sorts of, from spiders, snakes to jellyfish, and then other envenomations as well. Last week we had a toxin, so a young guy who caught a fish in the Brisbane River. I don't know why you would ever want to eat anything out of the Brisbane River, but he ate a toadfish and he ended up with paralysis from a tetrodotoxin. Everyone's probably seen that episode on The Simpsons where he gets poisoned, but yes, that was quite interesting. That's the second one that I've seen. We cover lots of different things, and we don't just see the patients through the PA emergency. We also provide a phone service. We get calls from lots of other hospitals and GPs and people throughout the state of Queensland.
I love that you guys are so adaptable and moving to the times and providing this amazing care to so many people in Queensland. It's the greatest. I tried my business case to sell it to my workplace to get an NP tox through, but they kind of weren't interested. Maybe it's just not the time. I think it's definitely a dream job of mine to maybe one day step into your footsteps.
Oh, no, that's for sure. It's very interesting. And I know there's a lot of published data from Australia to show the benefits of a dedicated tox unit. And it's not just for providing that sort of expert care for those patients that are severely unwell. It's more for the 98% of the patients that come in, and it's more about guiding an appropriate observation time or appropriate therapies in terms of decontaminations or specific therapies that they might require. It's trying to avoid lengthy observations and inappropriate management. It's trying to streamline the care for our patients and reduce bed stay as well as improve outcomes. There's a lot of evidence there for a tox unit. And like you said, with digital AMR now, with the visibility that we have on other sites that are on that system, it's pretty amazing. It makes it much easier to provide virtual service consults for poisonous patients. And we cover all the way up to Townsville at the moment in that written consults and written advice for them. Yeah, well, the goal is to try and take over the rest of the state when we can.
I also love that Kathy Zawadi, who is this phenomenal, powerful woman who I'm slightly scared of, and just gets it done and just doesn't butter up her passion and what she wants in life. And I guess some people get offside with that and other people just froth it. But you have to have that person of interest to really drive a niche specialty to be successful, right?
Yeah, that's for sure. It's not just her within the unit. Everyone's just amazing and high performing, and I feel like I'm just riding on their coattails and being dragged along for the ride, which I don't mind so much. I have my role within the unit and I really enjoy that. From a department that isn't renowned for having nurse practitioners, I couldn't speak highly enough of the support that I had coming into this role. I never once felt like I didn't belong there, and I never felt once that someone didn't want to take the time to explain and go through things for me. I feel like I've had the dream run in terms of going from registered nurse to nurse practitioner. Yeah, I felt the team enough.
Do you still have imposter syndrome though?
Oh, yeah, for sure. I have my area where I'm more comfortable with at the moment, but still for certain patients where they're quite unwell or they're complex, yeah, I still feel a little bit out of my place. But that's okay. That'll come with time. I realise I'm still within my first year of this, and maybe I can look back on this podcast in 20 years and see where I was and where I am now.
I hope so. I hope we're on to our 20th season.
Yeah, for sure.
Oh, gosh. All right. Can you tell us a day in the life of Ben doing P-Tox?
Oh, yeah. So usually it's nice. I get an 8 o'clock start. I'll come in and I'll look through our department and find anyone who's presented with poisoned or envenomed, whether that be they've already seen and they're admitted in a short stay or in acute or on the ramp. Unfortunately, on the ramp, who yet to be seen. So I'll go and identify all those patients, create a list, and then we have an inpatient service as well. So we have admitting rights under toxicology. Last week was heavy. We had a lot of inpatients through ICU as well as on the ward. I'll identify where they are, and in the morning it's myself and one of the consultants and sometimes one of the fellows. We'll go and round on our patients, work them up, whether they can be cleared and for discharge or whether we need to still provide some care for them and come up with a management plan. Then following that, it's providing that phone service. So other hospitals, GPs are able to call through. At any point I can get a phone call with a consult where I'll take a history and then provide them with some advice. Other roles throughout the day is there's a lot of research that we're doing, given it's summer and there's a lot of snake bites about. I assist with the Queensland snake bite project. So it's collecting information from venom patients, and that could be anywhere within Queensland. Then I'm doing some of my own research as well, which is around anticholinergic delirium. Then it's providing ad hoc education. This month or next month, I'll be running the nursing subspecialisation course within our department. Although I did that a few years ago, I'll be taking the reins on that. Then the other part is I do my own education. So I'm in a 2-year course currently, so about to start my 2nd year of the Toxicology and Poisons Network Australasia course. So it's a 2-year course that's targeted for medical officers who are doing their fellowship in toxicology to become a clinical toxicologist. And there's also some SPIs, they're specialists in poison network pharmacists that do the course. And that's again testament to Kath. She's the president of TAPNA at the moment, and she changed the inclusion criteria so that a nurse practitioner was able to actually enroll in this course, which is massive. I feel a little bit out of my depth most of the time with this course, but I'm learning lots and looking forward to this year about to start.
What do you think that the key learning points are for you in the course? Why do you think that you're learning so much?
Oh, because it's just on another level. It's extremely in depth. Most of the participants in the courses are already faced or consultants in their area. It's a lot of high level discussion. So a few things go over my head and I've got to go back and understand that pathophysiology or biology and get up to speed. But I guess where the benefit for me is I'm full time in a clinical toxicology role. So I'm seeing up to 200 patients or being involved in 200 patients a month that are coming through our unit, plus another couple of hundred phone calls that are coming in through the unit. So although I may not be laying my hands on every one of those patients, I'm involved and have access to those cases. So I have a lot of exposure. That's where I get that sort of real world experience in seeing these patients in the flesh, seeing the unwell ones, the not unwell ones, and getting a feel for how these patients present and progress through their stay. Yeah, it's a great learning opportunity for me, especially if I'm going to be staying in this role. And so, yeah, I couldn't thank Kath enough and everyone that's supporting me to be able to do this course.
I know that you're a sought after man now to have some nurse practitioner candidates follow you. So that's really exciting that you get to teach people. Maybe I should book in some time with you this year.
Oh, you're welcome anytime. But yeah, I've mentoring a couple of people this year. I feel like a bit of an imposter though. I'm like, oh, I'm only brand new, but I'm happy to share what I've learned so far. And I think the more mentors you have, the better. And you can just take little bits and pieces, and everyone has a story, like you say, and can provide hopefully some guidance for their journey.
Yeah, absolutely. I think that it's just a really meaningful process being in the candidate program and just having mentors that take the time to really teach you. My brain is really quite slow in uptaking the information, and so I have to ask a few times for it to sink in.
Tell me about it. That's me to the T.
So it's so awesome. We always talk about this history, physical examination, you're getting the diagnosis from that point of view before you even run a test, because in previous episodes we've talked about those pre-test probabilities. Can you talk us through a suspected toxicology patient, how you're taking the history and what key features that you're really looking for to guide where you're going on this?
Yeah, the part of the history that sort of separates tox from other areas is getting a risk assessment. This is probably the most important aspect when it comes to treating a poison patient, especially if they're not requiring immediate resuscitation. If they are requiring immediate resuscitation, then the risk assessment usually occurs in conjunction with that. What the risk assessment includes is one of the big ones, obviously, see what drugs have they taken, if we do know. So whether it's just a single agent or whether it's multiple co-ingestions or what in terms of envenomation, what the story around the bite and the time. Then if it's a drug ingestion, what formulation is that? Is this an immediate release or is this a modified release? Because that's going to change what you're going to be doing in terms of whether you're still in time for decontamination or other therapies. Then the time, this is a huge one. So the time's extremely helpful to determine if we're within the time frame to offer decontamination, like I said, or whether specific levels might be needed to be checked, whether we're yet to see peak toxicity or probably past peak toxicity. Then that can help define our observation period as well. The route, another one, and if they've ingested it, whether they've injected it, snorted it, shelved it, that's going to change the time to peak toxicity as well as whether it's going to bypass first pass elimination. Then going forward from them, what sort of symptoms have they developed so far? Are these symptoms in keeping with what they may have overdosed on or not in keeping with it? And that may make you go back and rethink your risk assessment again. And then comorbidities. Comorbidities are a big one. I guess, for instance, if someone with poor renal or liver function, they might have prolonged metabolism or clearance of a drug, or a patient with reduced cardiac function, they may not tolerate being hypertensive or tachycardic as well as a healthy person would. So if someone's coming in and they're unconscious or we haven't got much of a story, then it's about trying to think outside the box and looking for other ways to gain this information, whether that's with QAS, family or bystanders that may have witnessed something. With the digital records now, we have pretty good visibility in terms of their My Health record to see what they may be prescribed. And then we've got things like QScript, so the monitoring database where we can see, again, it's a bit more accurate in terms of if they have access to any controlled substances. So there's lots of ways. I mean, trying to work out time of ingestion for some people, like I've even asked them to have a look on their phone because they may have texted someone when they've overdosed it, so you can get a pretty accurate time that way. I think the risk assessment is probably what sets you apart in terms of taking a normal history for a patient that may present to the emergency department. And nurses also triage, so you may get a more accurate story from there, and then they may progress to be more sedated or obtunded, and you can't get a story from the patient themselves. So it's just trying to look at multiple ways of trying to put those pieces of the puzzle together. And then I guess if once we've got the risk assessments going on to assess the patient, like I said before, if you're looking for clinical features that are in keeping with what you suspect the culprit drug to be. So if someone's taken a sedative overdose, are they showing features of sedation? What level of sedation have they got? Say if they've taken a serotonergic agent, going through and looking for features of serotonin toxicity. So whether they've got your sort of telltale, may have big pupils, some tachycardia, but then the main one being, do they have neuromuscular excitation? So do they have inducible ankle clonus or brisk reflexes that are going to punch you that way? It's just trying to get that strong risk assessment and then assess your patient and see whether it's in keeping. And if it isn't, you go back and rethink things. So that's probably in terms of what separates tox from any usual patient presenting to ED.
In terms of your physical examination, what do you think that your most utilised examination would be on toxicology patients?
Well, the toxicology handshake, where you go and pop your hand in their armpit. No, that's not really. But so I would say that we're looking for level of consciousness. It's probably a big one because people may present with, you usually start with your A, B, C, but in terms of going through airway and what separates the tox again from, say, a trauma or head injury patient is GCS isn't probably the best tool to utilize for a sedated patient after an overdose. That's because we know that with patients that have a motor score of 5, so that they're able to localize to pain, they're generally going to have an intact gag reflex. If they have an intact gag reflex, they're usually going to be able to protect their airway. So, for example, you may have a patient who's GCS 7, so 115, and if we have a pretty accurate risk assessment and we know that they're a little way down the track and we are likely past peak toxicity, then we may be happy to move that person through to somewhere where they can be observed appropriately, but not too concerned that they're going to further deteriorate. And there's a lot of good evidence, and actually some recent evidence from 2023. There was an RCT in France. I can't remember which paper it was published in, but it looked at a conservative strategy, so withholding intubation for poison patients versus intubating. And they found that in the intervention group, they had fewer ICU admissions, fewer adverse events related to intubation, and then lower incidence of pneumonia. So it suggests that a conservative approach to intubation for poison patients with a lower GCS might lead to better patient outcomes and reducing unnecessary intubations or ICU admissions and associated complications. But again, it's much easier to hold off if it's someone that I'm managing in person, and then I can monitor, giving that sort of advice over the phone. This might be more of a junior clinician at a rural hospital. So the advice around airway management is generally based on their merits and what they feel comfortable with and what resources they have. But in general, we will probably tolerate someone with a lower GCS a little bit more in our department, and we're more comfortable with that, especially if we have that accurate risk assessment.
And I guess you have the nursing staff to support these patients as well, like being very on to doing these regular neuro and caring for them in a visual bay and just doing all the right things for these people so that risk is lessened.
Yeah, that's right. The nurses are amazing from coming up through having the unit, which was introduced in 2014. I feel like if a patient with a GCS7 was in another department, then the nurses wouldn't feel comfortable having them in short stay, but having them in our department, knowing that a toxicology team has seen them and they feel more comfortable having them they're still in a visual area and they're still on appropriate monitoring, but they feel more comfortable having that patient out there versus keeping them in a resus area.
I remember when they first moved to the short stay area, and it was crazy, wasn't it? I just think that the department is well supported by senior leadership and just making people feel supported, have a voice. Emily Cooper has done so well in that education portfolio. Jen hiring amazing people, and Karen, Tarima, geez, like you guys just have a powerhouse of a team that is just making phenomenal nurses. So yeah, it's awesome.
But yeah, it's a pretty special place to work, lots of opportunities, and I can't thank them enough. I wouldn't be here, obviously, without them mentoring and guiding me. But I guess that's airway. In terms of breathing, the main thing is we're looking for a good tidal volume. So it's a bit difficult to measure the volume of their breath, but we can have a good idea from their respirate as well as their oxygen saturation. And we can use like venous gas as well, or arterial gas to measure their PCO2 and to guide whether there's something we need to intervene with. Again, looking at breathing from an opioid toxicity perspective. So we've done a lot of work, and Kath Iswati, she's recently just put together her PhD around opioid toxicity, and she developed a nursing care plan that we have in our unit. So the nurses are empowered to administer naloxone if required based on certain triggers, and that's around like a respirate of less than 10 or oxygen saturation is less than 93% on room air. So we have a really good pathway, and it's shown greater compliance and more appropriate use of naloxone, which is amazing. Nurses are we're great at following sort of protocols, and if we have a patient in front of us and they hit a trigger, then they're more likely to follow through with that. And so that's a really great move that Kath's made, and we're using that a lot. And then it's looking through, in terms of assessing a patient, once you've got a good risk assessment, looking for that specific toxidrome. So like I mentioned with anticholinergic toxicity, so we're looking at pupil size. I mean, not all anticholinergics are going to give you dilated pupils. They may have some alpha antagonists, so you won't get that. But we're looking for the signs of increased heart rate, reduced bowel sounds, whether they've got dry axilla, dry mucous membranes, and urinary retention. That's a big one. And then as well as anticholinergic delirium, which is probably the most difficult feature to manage in terms of nursing. We have some really good strategies and management principles and antidotes that we can use for anticholinergic delirium. It's probably one of my favorite because it's got an antidote that you can have someone who's delirious hanging from the rafters naked, and you give them some physostigmine, and then all of a sudden back GCS 15 having a cup of tea and telling you a story about how many tablets they took. So it's probably one of my favorite toxidromes if I had to pick one. I went through a little bit in terms of serotonergic effects before, and then you got the others opposite to anticholinergic in terms of cholinergic poisoning. Then you got sympathomimetic, which most of our methamphetamine patients may present with. So you've got to think about that, I guess, in terms of having sympathy. If you think about having sympathy for a person who's being chased by a bear, so they're going to have all those telltale sort of features, a high heart rate, they're going to probably be sweating, they're going to be agitated and restless. So you can see how a lot of these clinical features may overlap with each other, but there's certain different specific features that you can differentiate a toxidrome from another one, and then that guides your management for that. So methamphetamine is one of the main cohort of patients that we'll manage. So we see around anywhere from 80 to 100 patients in a month who present acutely intoxicated. And I guess our unit manages acute methamphetamine intoxication slightly different to other places where they may get an early referral to mental health because they present with psychotic symptoms or an agitation. That's usually the two things that are going to get someone to hospital. So we will admit them under toxicology, and it's usually about giving them a sleep. So assessing them, determining their needs. But a lot of the times it's about providing that really good supportive cares and some time for the intoxication to wear off, and then to see whether those psychotic symptoms wear off. So we'll usually try to use droperidol. And I know a lot of other hospitals may use droperidol as a first-line parental sedation for a severely agitated patient. But with methamphetamines, they may be severely agitated, and that's why we use drop. But we also would use it for someone with mild agitation, and it's more around the pharmacokinetics and dynamics of the drug. So it's where it targets its receptors is really important. So with methamphetamines, you're getting a massive release of noradrenaline, massive release of dopamine, and droperidol has great noradrenaline blocking and dopamine blocking activity. So it's more of I guess you can nearly look at it as an antidote for methamphetamines, and it works much better than titrated benzodiazepines, we find. They get it much quicker and decent sleep. Most of the time they wake up quite nice, and 90% of the times their psychotic symptoms are resolved, and we're able to link them in with appropriate services in terms of drug and alcohol and homeless services and things like that prior to discharging them, and they can avoid a mental health assessment. So I think that's probably what differentiates us managing them under the tox unit versus other hospitals that don't have a tox unit, and they might end up on a recommendation and on the ward for a day.
I got you to do an in-service for my hospital to kind of promote tox to nurses. And you definitely taught me that. I guess as an emergency nurse, I'm always about, defueling the situation, de-escalating, and using my words and trying my best to avoid droperidol. But ever since you've told me that, I'm like, droperidol first, because it works way better, and you're absolutely right.
Yeah, it's not a punitive measure. Try and sell it as an antidote. And I mean, antidotes aren't just one mechanism. There can be increasing the sort of clearance of a drug or supporting a patient through versus direct receptor antagonist or agonism to manage that poisoning. And droperidol fits in that basket for me. It's up there with NAC and naloxone and physostigmine and things like that. It is quite a safe drug. I mean, we've been using it for a long time now. I know that one of the fellows in the unit is looking at publishing some data around our droperidol use and the minimal adverse effects that come with it. It's just been a massive change. I know the US is coming around, but it was black box back in the day after it was made to look like it was associated with QT prolongation. And I don't know the ins and outs, but I know it was these publications came out about the same time as ondansetron was released. So I don't know what big pharma, what happens up there, but we've shown lots of evidence with our dorm studies in ambulance and in hospital that it's not associated with QT prolongation, and there's minimal adverse side effects. So yeah, it's quite a safe drug. We use it a lot.
So your neuroreflex testing is excellent, I'm assuming.
I can definitely induce a clonus. And yeah, so that's probably one of the main ones in terms of, like, it's very rare that with a tox patient that you're going to get neurological deficits other than increased reflexes, tone, and inducible clonus. So it's a lot of lower limb stuff. The other one is with venomations. If you're getting a neurotoxicity, you may have a descending paralysis. So although my full neuro exam is not the strongest, I can definitely get a clonus out of someone. And I feel like I can pretty well differentiate between ocular clonus and nystagmus now, so that's always helpful.
That's awesome. What are the most challenges you have encountered in your toxicology cases, and how are you navigating this in your clinical reasoning?
So holding the phone, you get a lot of calls, and it may be from another inpatient team or within the hospital or somewhere else, or even within it may be a patient that's a bit of a clinical conundrum, and the question is usually, well, could this be tox? And I've found out that the answer to that is, well, it could be. So it's about trying to go through, and then these are complex patients, and I'm learning to focus on them with a tox lens, and I can't know the ins and outs of every other system that's being involved in this patient, but I can look through and take a history and look at the drugs that they have access to, and then assess those patients to see if they have any clinical features that fit within a bucket of a toxidrome or something that we may think may be a result of poisoning or exposure. So that's something that I'm learning to deal with and expand my knowledge around that area. So that's probably one of the big ones is, could this be tox? And usually it is. There's also the multiple phone calls that you get, and also patients that I'm seeing that you get a call and be like, oh, this person's been exposed to aconite. And I'm just like, what is aconite? I haven't even heard of that before. So it's being able to take a good history over the phone, get whatever relevant information I think is necessary, and then coming to that realization that I don't need to have all the answers straight away, that I generally have some time to go away and look up cases and look up gold franks and learn about this exposure, and then discuss it with one of the really knowledgeable people within the team. I usually turn to Keith, and Keith will just opens up his encyclopedia within his brain and can just go through all of the history of the drug and all of these other cases, and just, I don't know, he just pulls stuff out of his brain and he's like, oh, as you know, and I'm like, no, I've never heard of this. So there's always someone, but I've learned to and not just rely on them. I try and look up and formulate, plan myself and advise myself, and then check that with one of the consultants. So it's just trying to learn. But I think that's just part of being a brand new nurse practitioner. Like, you come out of it and you feel like you're meant to know everything. And now I definitely realize for every one thing that I learn, I realize there's another 10 things that I don't know. And I've learned to embrace it, I guess, and not see that as a bad thing, that see that as a great thing, and that I can expand my knowledge base and help me going forward. And it's definitely seeing it now, I guess a year in, where my first lead case that I got a call about, lead exposure, and now I've had a couple since, and I can go through what's important in terms of where the potential exposures are, what a level is associated with what clinical features, and then at what levels do we need to look at collating, treating this patient. So yeah, I'm really enjoying that journey of learning. And I think I was fearful initially when I rolled out as a nurse practitioner, thinking that I needed to know everything, and people call you thinking you're going to know everything, but it's okay not to know everything. Journey, that's important.
We talk about this macro and micro learning. We talked about it off air before, and I talked earlier with Nicola Cooper, who by the time this episode's released, people will hopefully have listened to it, and about the clinical features. And you've done something similar with Keith. Can you just tell us about Keith first, who he is, and then what you've been doing with him for your own learning?
Yeah, Keith is one of the clinical toxicologists within the team. We have 5 now at the moment, and then a couple of fellows, but they're all amazing. But Keith sits next to me, and last week I was trying to find some odd random case reports around poison patients, and then taking out some of critical details that would give it away, but present him with a case and see if he could put forward some differentials and try and work out what it was. I've stumped him a couple of times, but there were some weird ones that I gave him. But it's just interesting to learn from him and go through what particular information is his key information, and that sort of puts together formulating his differentials. So it's something that I definitely want to continue and start challenging some of the other consultants within the unit. But I think it's a really good way to learn, and especially for me, because I can feel like I can have a read about the case report and I'll be learning about what this toxin is as well. And then if they've never heard of it before, I can actually talk about it a little bit in my very superficial way. But yeah, so it's just, I guess, thinking outside the box and trying to use other ways of learning and expanding my knowledge.
Maybe we can get Keith on here and do Stump the Chumps with him.
Yeah, you'll find it hard to stump him. I remember talking to him about a lead case, and he's like, oh, as you know, don't you remember that guy back in the early 1900s who made leaded fuel, and he poisoned himself? He didn't tell anyone, and he still rolled it out, and then he poisoned this whole generation of Americans. And he said that's why they have unleaded fuel, and it's filled with ethanol rather than lead to stop the engine knocking. And when he talks to me like that, I feel like I can recall that information better than if I'm reading it in a textbook. So I'm really lucky to have a room full of these exceptional minds. I feel like I can just be a little guppy in that room of sharks, but I can try and just soak up some of that information as it comes along.
I think that people's perception, and honestly believe this still today, is that people think that learning is through reading and doing a university degree and actual academic study, where there's so many more ways to learn. And that's by listening to these cases, talking about it, and going back and reading up on it with academic papers to support it. This podcast is this way to learn differently, right?
Yeah, that's right. Everyone learns differently. And I could definitely prioritize ways of learning or learn other ways to learn. And that's why I've really enjoyed listening to your podcast as well. And I feel like it's helping me in my practice. And I guess we never stop learning, do we? So
no, absolutely not. Blocking out these big parts of your day to learn, you don't have to do that anymore. 5 to 20 minutes. It's all you need to keep learning and keep fueling your brain. I kind of want to get that out as well. But thanks so much for that feedback. I love how many people have actually tagged onto this. I'm shocked. But yeah, it's all because of you guys coming to participate, not me. I have no knowledge whatsoever.
Oh, no, that's not true.
In terms of diagnostic tools, how do you prioritize, interpret what tests you're going to do to guide your diagnosis in tox case? Because obviously some tests are really expensive and might not be necessary. And sometimes it's just time sensitive and you might not be able to run a test.
Yeah, that's right. And then again, it comes back to that risk assessment, trying to get a good story of what culprit drug we're dealing with and then what time we're looking at as well. So the other specific management and treatment within toxicology is the first thing I usually think about is, are we within a window where we can decontaminate them? So for immediate release drugs, that's usually within that 1 to 2 hours where we would offer activated charcoal. And then for modified release drugs, sometimes up to that 4-hour window. But then there's also these little nuances in there. So is this a massive ingestion, or is this an aspirin that we know is going to form a bezoar and be fizzling away and getting erratic absorption? So we may want to do repeated dose activated charcoal, thinking like that. Or is this drug not amenable to charcoal and we need to offer them some whole bowel? So I did whole bowel last week. I've only done that 3 times now, but we had a massive extended release lithium overdose. So he had 45 grams, and he presented just on that 4-hour mark, and he was relatively asymptomatic. He just had a bit of a tremor, but his GCS was 15. So he was at a point where we could start whole bowel. So that was a fun experience, more so for the patient, but it didn't get him out of the woods. He still ended up going on to needing dialysis, but it was definitely a way that we could reduce some of his absorption. And then the other thing to think about is if it's early and we might ask gastro to see if they can come and scope the patient and remove some of that drug. And that's more so for really massive ingestions where we know it's going to form a bezoar, or whether it's like a metal or something that's not going to be bound by charcoal and they're going to need intubation anyway, so they could come and try and retrieve some of that drug. And that's happened a couple of times down within resus, and that's always fun to watch, but it's not always that easy to do. In terms of other diagnostic tools, we use ECG as a primary screening tool. The main 2 things we're looking for is sodium channel blockade or QT prolongation. And again, this comes back to the drug. Is this a drug that's known to cause QT prolongation? Have they taken 600 of citalopram, and we know that's associated with long QT, so we need to monitor this patient a bit closer and make sure that they don't get that. And if they do get it, then we instigate the right treatment to avoid getting a torsades. Or if this is a drug that's known to cause sodium channel blockade, and that's what we're looking for. And the big one is like a big TCA, so big amitriptyline, that may be early and may have features, so channel blockade or cardiovascular collapse. So that's a big one. There's other drugs like cardiac drugs that are going to cause bradyarrhythmias or blocks or ventricular arrhythmias, but that's usually an extension of their desired effects. So that's a pretty routine screening tool that we use as an ECG. And then we can do specific levels for certain things as well. For like salicylates, Panadol is a big one. That's our second. Always comes up second in terms of our most presentations for the month. And that's just because it's so readily available. But paracetamol levels are relatively cheap. I think they're only like $17 or something like that. But the risk assessment, so knowing when the time of ingestion was so that we can do at least a 4-hour level to plot them on the nomogram and determine whether they need further treatment or not. Lithium, I had the guy last week who had some whole bowels and then went on to needing dialysis. So lithium levels are needed in terms of utilizing them to guide whether enhanced elimination with dialysis is needed. There's other things that come into play, but based on a level alone, you will be able to dialyze them. You can do valproate and digoxin. There's lots of other levels you can do as well. Warfarin, superwarfarin. So there's many levels that we can utilize. Some of them we can turn around within an hour, and then others, like you said, can have a delayed. So it may take you a day to get a digoxin level. So you might not be able to use a digoxin on its own. You need to look at other electrolytes or clinical features and ECG to determine whether you need to instigate digifab. And I mentioned enhanced elimination. So we usually use urinary alkalization for certain drugs. I had 2 aspirins last week, actually. Last week was a big week, but we had 2 aspirins that ended up needing urinary alkalization. So that's generally, you can instigate that based on if they have a respiratory alkalosis. So usually if their CO2 is less than 30, or if they have a level that's greater than 500, or it can be some leeway if they have impaired renal function. But so that's a way of alkalizing their urine to increase the clearance of salicylates. And then dialysis is another one. So if it's to dialyze a drug off, or if it's a dialysis to correct their acid base to support them through until we can turn them around. You can also use bedside echoes. So if it's a cardio drug, or if someone's come in vasoplegic, bedside echoes are quite helpful to determine if there's a problem with the pump or if it's just a problem with the pipes. So if it's a problem with their heart, then that's going to guide what sort of presses you're going to use or what other therapies you might instigate, such as like high dose insulin, euglycemic therapy, or whether they need to go on to be a candidate for ECMO. And then there's not really, in terms of imaging, there's those patients that present following a sedating overdose who may have had an aspiration event. So you can use chest x-ray to look for that. But otherwise, specific things, I guess, like abdo x-ray or chest x-ray, if they've had a metal ingestion, so if they've had an iron or potassium, just to see if we can identify that on the x-ray, just to confirm that ingestion, and that might guide what decontamination you're going to do and what treatment you do from there as well. So they're probably like the big ones in terms of diagnostic tool. And like I said, it comes back to what they've actually taken, and then that's going to guide what you're going to do.
But definitely the armpit test of the
Yeah,
sweat.
yeah.
For people that don't know, there was a paper I don't even know, I think it's like a 1995 papers on the best way to assess fluid status, and checking someone's armpit to see if it was dry or not had the most success of testing that fluid status.
Yeah, I definitely don't have a thing for armpits, I promise.
It's actually a real thing.
Yeah, it's a real thing, yeah.
I'll try to link the paper to this podcast so everyone can have a read. Can you share a memorable tox case where your clinical Riesling played a pivotal role, and what lessons did you take away from this experience or lack of reflection?
Yeah, I guess that's a good question. I mean, hard to pick one. I mean, there's been a few really, it's probably more those really unwell ones that deteriorate in front of you, or there's something more memorable about the case that I guess sticks with you. And I know I did a talk for you earlier about a overdose. But there was another case that's come to mind actually from the middle of last year, where I got a call from the Metropolitan Hospital, but a smaller hospital in Brisbane. And it was a consult about a patient. And I think the initial call, it was from one of the registrars, and it's like, oh, I've got an interesting one here. I think they're a caffeine overdose. They've been drinking 20 litres of Coke. And I'm like, oh, okay, could you tell me about what's going on? And then I started to gather some of the history, and it was I think it was around a 60-year-old gentleman who presented there. I think it was early morning, like 2:00 in the morning or something like that. And he came in with agitation. He looked intoxicated, alcohol intoxicated, and I think he was allegedly hallucinating. And the call came in from someone living in his house who noted he'd been agitated and throwing things against the wall throughout the day, and was definitely not himself, but didn't really know too much about this guy. And then the phone call went through early in the morning, and he presented to this hospital and was being worked up. I got a call, I think it was mid-morning, like 10:00 in the morning, when they said, oh, we think he's had too much caffeine, and just gathering some of his story and then looking at some of his blood. So he was inebriated, he was tachycardic, his blood pressure was okay. But I guess the thing that stood out for me on his venous gas on arrival, he had a lactate of 18, and it was slowly improving through the course of the morning. I think when I got the call, it was like maybe 12 or 13 or something like that. But he hadn't clinically improved. He remained inebriated, remained tachycardic. His blood pressure was still okay. And I guess for me, it's usually looking at these cases with a tox lens. I mean, you can look at other causes for increased lactate, and I guess like a big one is if they were septic, but generally they're going to be shocked. They're not going to be sitting there with a pretty good blood pressure, or they have Cs, but you'd expect that over the course of that 8 hours that they'd been in that department, that the lactate would have cleared a bit quicker. So then you'll start thinking through what are the high lactate causes for a poisoned patient. And you can think about a massive paracetamol or a big iron or a big salicylate or anything that's going to cause mitochondrial uncoupling. And then the other big one, is this a toxic alcohol? Is this an ethylene glycol? So we gave some advice to begin with. And I guess the thing that I initially thought this is going to be an ethylene glycol was that he was inebriated, so he appeared intoxicated. And he had although he was tachycardic, he had a pretty good blood pressure. And he had already had a mild kidney injury. I think he had his creatinine was around 130 from memory on arrival. And again, not much history was known from this guy. I think he had just moved from interstate and not known what medications he was on. So the other thing I was thinking is he got access to metformin or something like that. So I gave them some advice to go away and do a lab lactate. So send off a lactate level specifically to the lab rather than one that's coming off the gas machine. And then to do an ethanol level as well as an osmolar gap. And then once those came back, then I had a pretty good idea what was going on. So he had a lab lactate, I think it was like 1 or 2, so it was nothing. And his lactate through the gas machine was 12, and he also had a slightly elevated osmolar gap, and his ethanol was less than 10, so it was, or whatever it is, a 0. So then that, knowing after looking after a couple of ethylene glycols in the past that this was going to be ethylene glycol, and that's because the gas machines, I don't know if it's a fault, but it's just the way that it analyzes lactate. It confuses glycolate with lactate, so it's a mimic. And with ethylene glycol, it's metabolized by alcohol dehydrogenase through a couple of pathways, but ends up as glycolate, and then through to calcium oxalate crystals, which get deposited in the kidneys and then go on to cause your kidney injury. So this gentleman had a definite lactate gap, so of about 10. And there's nothing else that would give you that gap. So that alone was we were able to come up with the diagnosis and then give advice around what treatment. And at the time, we didn't have fomepizole or access to fomepizole, which is an alcohol dehydrogenase inhibitor. So we were using alcohol. And I guess that was another thing that drew me to tox. I remember treating a patient back when I didn't really know too much about what was going on. And I just thought, we're giving someone vodka to treat them. I'm like, this is one of the coolest things ever. So I'm like, this is something I need to learn about. So we're gone are the days now that we have fomepizole. We don't get to use that anymore, but you never know. We might run out of fomepizole or be at a hospital that doesn't have it. But yeah, so we asked them to start loading this patient with ethanol, and ethanol will compete for the metabolism with alcohol dehydrogenase. It has a much higher affinity than ethylene glycol. I think it's about 100 times more affinity. So it's more likely to metabolize alcohol over ethylene glycol. So they were able to load him with that. They somehow got him to drink it, which is really good. Generally, we need to put a nasogastric in to give them 4 shots of vodka. But yeah, so you'd had his 4 shots of vodka, and then they transferred him to us. And I saw him at the ramp as he got triaged. I think he was like 3 or 4 in the afternoon by now. It took a little while for him to get there, and saw him, and he was quite delirious, still appeared intoxicated, but otherwise stable. He had a slightly worsened renal injury, which we were expecting. So then he ended up going straight up to ICU and had to be intubated to be able to line him up with a VASCAth and put him on the filter and to manage his behavior. And he was a bit of a later presentation ethylene glycol. He had already started to metabolize most of his ethylene glycol, and we knew that because his osmolar gap was closed, so he didn't have a gap. And we look for an osmolar gap is because ethylene glycol is a coolant and it's an antifreeze, so it's going to raise the freezing point of your blood. So that's where you get the raised osmolar gap, and that would close. So it makes you think that he's metabolized most of this to glycolate, and that's why we could get an osmolactate gap. And then he's already got a kidney injury, and it's most likely because he's already depositing oxalate crystals into his kidneys. So yeah, so he spent a couple of days on the filter, and I ended up being extubated, and I think he was in hospital for a couple of weeks, but it got to the point where he's discharged home with no burden of injury and was able to go home and continue to live his life. We could never remember how he ingested ethylene glycol. I don't know the circumstances around that, but there's nothing else that this could have been. But I remember when I got the first call and I'm like, how much caffeine's in Coke? And how much is 20 liters? And I was like working out how much caffeine's in there, and then I knew that the toxic dose of caffeine's around 50 milligrams per kilo, and he hadn't quite got to that. And I'm like thinking he's drunk this over the course of a day. So I'm like, I don't think this is caffeine. But that was probably one of the ones that sticks in my brain a little bit.
That's a great case.
Yeah, he was good.
So good. We're coming to the end of our podcast, but do you have any tips or tricks or words of wisdom for people either thinking about undertaking their NPs or are an NP student, or even NPs that have just graduated?
Yes, and that's a good question. And I've even had a conversation with one of the other nurses in our department this week who called me and was thinking about doing his NPs. And I just think if anyone's out there thinking about doing their nurse practitioners, just pull the trigger, start chatting to other NPs that you can get access to, having chats to your senior nursing team, having chats to your senior medical team about how this can look. And I think if you've got that little flame that I had for whatever that 12 years was before I actually did it, I think you just need to do it sooner rather than later. Don't wait for a time in your life where you think it's going to be easier to get the study done. It's always going to be challenging, but you just get through it, you do it. I don't think you should wait. So yeah, I guess that's a big thing for me. Pull the trigger, start doing the study, and then everything else will eventually just fall in place. There may not be a job that you walk straight into. I was extremely lucky, but you can make that happen. You just got to show your worth, I guess, show the impact that you can have on the healthcare system, on your patients, improve their outcomes, and then for your own well-being as well. Like, I enjoy going to work. I find it extremely interesting. Yeah, there's some really busy days where you feel like you just don't get a minute to stop and think, but then you can reflect back on those. And I'm extremely grateful for everything and everyone that's helped me get here, including my wife. She used to take the kids for walks and get them out of the house so I could sit home and study. So I definitely couldn't have done without her. I couldn't have done it without my nursing mentors. I couldn't have done that without my exceptional medical mentors and their leadership. But I think if you're having the thought to do it, don't wait till next year. Just do it straight away.
I think providing good patient care and having enjoyment in a job means that the job should bring you joy and have meaning to you. Yeah.
And then don't think you need to know everything straight out, because I definitely don't. And I've learnt to embrace that. So we're all learning together and we all learn differently, like you said, and it's just got to enjoy it.
Yeah. Well, thanks so much for taking the time to speak with us. And I'm definitely going to hit you up for Keith and you to do Stump the Chumps.
Yeah. And like I said, you're welcome to come up the motorway any day and come and spend some time.
I absolutely will. And if anyone would like to reach out to you, are you happy for them to contact me and I'll get you in touch?
Yeah, that's fine. Yep. No worries.
Cool. Awesome. Thanks so much. Thanks for tuning in to this episode of MP in Progress. I hope it gave you some valuable insight and inspiration as you refine your clinical reasoning process and progress on your journey. If you'd like to catch video content from the podcast, don't forget to subscribe to our YouTube channel, MP in Progress. For updates, behind the scenes moments, and more, follow us on Instagram at MP in Progress Podcast. Keep learning, keep growing, and I'll see you in the next episode.